So, how's your caveman squat coming along? Have you been taking your benchmark photos of your side shot from when we first started out in part 1? Let me know how it's coming along, because we're now into part 6. Part 6, we're going to be talking about the knees, and apparently this is the hot topic when it comes to squatting. Lots of questions about the knees in relation to your squats. I'm going to be going over those a little bit later on. So some of the guidance that we get in our training as personal trainers or exercise professionals is very often about alignment. And yes, that is appropriate to some degree. If you can see a huge deviation from a good alignment, then we probably need to correct that. The biggest question is always, is that poor alignment due to technique or a problem from above and below the knee, creating a different line of that knee's positioning? Now, I'm not sure if you've ever heard your knee called your middle sister, but it's just a kind of a nickname for the fact that the knee is directly influenced by the pelvis above and the foot and ankle below. And so, more often than not, while the knee presents with pain, problems, discomfort, more often than not, that's not where the root cause is coming from. Now, the knee doesn't just flex, there's kind of a glide and a roll with the flexion to create the appearance of knee flexion when we're moving and through motion. So if you imagine a stiff or unstable pelvis and or a stiff or unstable foot and ankle producing force through this joint, you can imagine how this can disturb what's happening at the knee. So please go back, revisit pelvis, spine, nerves and shoulders before working on this area of the body, because all of that is over and above and creating descending force through your knees. And don't worry, it's ankle and feet next time. So if you have a stiff or unstable pelvis or a stiff or unstable foot or anything going on above the knee, then that can create a higher risk of injury or trauma. Obviously not immediately, but over time it's that repetitive use through poor movement biomechanics can actually create problems around the knee in exceeding loads through a certain area rather than distributing it through movement. So just to go back to context in relation to alignment. Alignment is an extrinsic guide and we should use that, but just be mindful that we're not looking for perfect lines. More importantly, what we're looking for is great function and movement. The problem is, how do we know whether we need to be looking at alignment or if what we're seeing is poor function and movement? Ideally, we need to understand how to test movement, and that's for each individual area of the body so that when we put it all together, we can understand the root causes of our movement issues. So in terms of protecting the knee, yes, go back, part 2, 3, 4 and 5 come in advance of this section. But is there more that we can do when it comes to understanding the knee? Yes, of course. So we're going to be doing a couple of tests for this section, understanding your knee stability. What you will see when we get to the exercises is how the knee is directly, or knee stability is directly impacted from the joints above and below. I don't think I need to keep reminding you, the body is an integrated system. Everybody's saying that, people are not practicing it. Every exercise, every technique, every test you do, you should take into account the entire system and the context within which you are looking at it. Okay, what can we do to test the knee? Well, once you've got the pelvis, spine and shoulders moving a bit better, once you've mobilized those nerves, then these two tests are a really great add-on. Okay, so this first test is called ligament dominance, and what I'm going to be doing is dropping from the box to see what happens to the knee every time you land in a downward force. So when running, even walking to some degree, coming down some steps, we're going to see what the knee does the moment the foot hits the floor. So what you'll have seen on this clip is how the knee, the foot and the ankle stay in a relatively straight line the moment the foot hits the floor. This is good. But what you will notice in this second clip is how the knee actually deviated medially, knee valgus or knock knees, the moment the foot hit the floor. And that was a lack of control from the pelvis that doesn't stop that knee from dropping in. What this means is that this knee is ligament dominant. Now this isn't a good thing. If the ligaments are taking all the load and the muscles aren't controlling it, then the ligaments are at an increased risk. So this is where what you'll see is my better knee is actually the one that I ruptured my ACL in. So why is that better than the other one? I rehabbed that leg. So there's a tip for you. If you ever do rehab, always do both sides, even though you may only damage one side. So just to clarify, the drop box height is around about 31 centimeters if it was to be done as per the research. You need to drop straight down, the back foot comes straight off, the knee should flex to around 30 degrees. You don't need to hold it, but the moment you are taking the benchmark is the moment the foot hits the floor. If your knee deviates medially, you are ligament dominant and you are at risk of damaging ligaments like the ACL, again, which is a common area for people to damage. So what do we do about that? Well, if you think that the problem in that movement, the lack of control, is coming from the muscles above. So, as the knee hits the floor, these muscles are not able to stop that medial motion. So that is adduction, internal rotation. So what we need to work is abduction, external rotation, in the hope that over time will reduce that medial knee drop. So what does that look like in terms of exercises? Well, ideally we want to be periodizing and we need to make it client specific, but the very easiest low level would be quite isolated and basic exercises, something like this. So if you imagine that the abductors are the ones that are struggling, you could literally use leg weight or body weight, sideline hip abduction, or even clams, which will work the external rotation, or any variation of those techniques to start to make things a bit more interesting. We could also add a resistance band around the knees. You can add seated clams. You could add some hip extension and then abduction. We could use body weight, so from here, lifting up. Do you remember from the pelvis? Or even a longer lever. So that what we're doing is we're gradually adding more load, more challenge to the abductors and the external rotators. What's great about this program is you can just go back to the test at any point to see if it's improving. If it's not, you modify what you're doing, you readdress, you change the exercise technique and retest, and then when it's starting to improve, you know you're going down the right lines. How else can we progress those moves? Well, the ones I've just shown you were all lying down. Of course, we can do things seated or standing like this. Again, same idea as lying down, but in a seated position. You would amend the band depending on the client, the range, etc. If you're in a gym environment, you may have the seated abductor machines, so you can use those. You can add a lot more weight onto those. And then, of course, you've got a harder neuromuscular challenge by coming onto just your 2 feet, and then if you lift one leg, of course, then you're going to be challenging your balance, which technically gets you closer to what we're trying to achieve in relation to the test. So I'd just like to say at this point, for all the functional movement fans who are maybe wondering why I'm doing isolated techniques here, why I'm teaching you isolation techniques, let me just explain. We are all aiming towards full function. That's exactly what we're aiming towards as well. However, if you have one area of your body that is not working so well, the joints above and below, the other muscles will compensate and give you what looks like great movement. So what we're doing here is creating better function so that you can be more functional over time. And the periodization will get you there, but what we're doing is breaking down the bits or working out which bits are not actually doing what they should, improving those ratios around the hips, the hip strength ratios, so that we can start to bring ourselves back up to the function and fundamental movements like squatting. So this next knee stability test is to assess your quad to ham ratio of strength. So your quads should be stronger than your hamstrings, and average people around about, your hamstrings should be around about 70% the strength of your quads. But for many of us, due to our lifestyles, our hamstrings are actually down by more than that, too much. So this test is specifically designed to demonstrate whether your hamstrings have the strength to coordinate with your knee extensors, your hamstrings obviously knee flexors, hip extensors, so that when you jump forwards, they're able to engage, stabilize the knee, and give you a solid landing. So with this particular test, the quad dominance test, what we need to see is a big forward jump around about 1 meter from the standing leg onto the same leg. So you're doing a hop. So the leg that you're not testing just stays mid-air, you keep that knee bent, and then when you leap, you land on the leg that you take off on. What we want to see is that when you land immediately in 90 degrees at the knee, ideally 45 degrees at the hips, so quite upright, and then you should be able to hold it for 3 seconds. Have a go. If you miss one of these points, it could be an indicator that you need to work on your hamstring strength. And so all we need to do is isolated hamstring exercises. Ideally, we want to really focus on hamstrings in terms of knee flexion, because they are the strong knee flexor, but we can gradually start to introduce hip extension exercises, even though they will be bringing in the glutes a lot more. So some fantastic exercises to isolate the hamstrings. In a gym, the machine, the seated leg curl. And if you imagine the seat back, ignore it. And if you hinge forwards whilst you're doing that technique, what you will get is a bigger range through the hamstring and a more effective contraction. Another great exercise, which is quite advanced, some of you may have seen on my Insta profile, is the Nordic lean. I think I've heard it called several different things, where you are kneeling, you have the ankles supported, and then you literally extend at the knee using body weight. That's an awesome exercise, but it's pretty intense. I started on about 3, and I've worked my way up to around about 3 sets of 8 now. But let's just focus on some really simple hamstring exercises, because I have no idea who your clients are going to be. Now, if they can perform this test, I would imagine they must be to some degree fit and agile, even if that's on a kind of like a low level or even an advanced level. So some great techniques would be seated band knee curls like this. So you need a studio floor that you can slide on, and then you can literally drag the mat, a towel, a sweater along the floor, push it back out, drag again, release. You could do one leg at a time, or even tie a resistance band in front of you or a cable, and then leg curl from here. Again, if you can get more range through the hamstring prior to working them, it's a more effective way of training the muscle. Then of course you've got the hip extension component, so your deadlifts, your good mornings, single leg cranes are all, again, great exercises to work on the hamstrings, but they would be more along the line in terms of periodization. So start super easy, super isolated, aim for the knee flexion component first, And then you can add in a little bit of both, start to advance it on and get creative. So how does this all relate to squatting? Well, when you squat down, you're using your knee flexors extensors, your hip flexors extensors, your ankle dorsiplantar flexion. So every part of the lower half of the body is going to be involved. If you have any instability, dysfunction, or any compensation occurring within the body, this can impact on your technique, it can impact on your strength and performance, and it can increase your risk of an injury. So this is the topic that generated the most questions. So I'm just going to run through some key ones here. So Catherine Turner Perro asked, knees coming together excessively. I think that was a question, and I think what you mean, Catherine, is does it matter? What do we do? How do we test that? There are a whole plethora of reasons why the knees can be coming together. If it's excessive, as you've described, it's probably not a good thing. The question is going to be, why are they coming together? What you'll notice is if you watch the Olympic level, Olympic lifters, for example, their knees will come together when they're driving from the bottom of an A2G squat position in their snatch or clean. And I was asked this the other day, does that matter? Why does that happen? If it's not excessive, what's going to happen is the body is going to try and be efficient in getting the force production underneath the direction we're trying to go in. And if you imagine lifting a heavy load in the arms, on the back, or wherever you've got it positioned, then the knees are going to come in to oppose the force coming up, or the ascent. However, if it's excessive, there is an increased risk. Just remember that the GB athletes are very conditioned, very well trained. They've got all sorts of professionals working around them. For the amateur, we need to be mindful of risk reduction. And so better lines as best as we can is probably a good thing. Now, excessive movement, Catherine, ideally we want to be doing tests like the two I've just shown you, particularly ligament dominance, which is actually an impact test, so it doesn't directly relate, but it might give you an indication of a weakness or a dysfunction around the lateral hip muscles. So Catherine, go back to pelvis and then come back to knee. So when it comes to stability around the knee, don't forget the strength through the hip, ab and adductors. Remember back in pelvis, we talked about working those adductors first in relation to the antagonist work to the muscles that we were releasing. If this language is all a little bit complicated for you, just go back to part 2, have a listen, have a watch, and you'll be able to see exactly what I'm talking about. The strength ratios around the pelvis should be 1-to-1 hip, ab, and adductor ratio of strength. And again, flexors and extensors of the hips should be 1-to-1. If this is off, this is going to impact on a descending force through the knee. This can create the instability, and this is why we're using specific techniques and exercises to change those ratios. So question number 3 is from the Ginger Ninja. Should you be squatting with a meniscus tear? So I'm afraid this is absolutely a case-by-case question. I cannot give you a direct answer on this. I'm sure the response would be in some cases yes, and in others no. If there's pain, if there's a problem there, then really we should be seeing a consultant or a clinician to understand the risk. A meniscus tear could irritate the knee, but some people can get away with it for a certain amount of time. So it's totally case by case, and it's down to the individual. They must see a clinician or a surgeon or somebody that can guide them. The next question I've got is Antoine, and he's asked about, or he just said, knees passing your toe. I think again, what he was referring to, is this okay? How much is it allowed? And again, like anything, it's all about function and performance, or function and movement that's good and healthy for the individual in front of you. So anything excessive is going to increase the risk. If you're going down ass to grass, there's more chance that your knee is going to travel forwards over the toe. Does this matter? It depends, and I'm sorry if it sounds like a cop-out question, Antoine, but the knee is probably going to travel forwards, and the further you go down, or the style of squat, or your limb length is going to dictate how much that is going to happen. The more forward the knee goes over the knee, then it's going to change the force running through the knee, so the risk will increase. Does it matter? Sometimes, not always, and so I'm sorry, but it's a very case-by-case, it's definitely a case-by-case question. There are people out there, there are strength coaches that will argue it doesn't matter, the knees should pass the toes, And in some cases, that's absolutely right. What we need to do as coaches or looking at our own technique is decide, is it excessive? By understanding, is there any load on the body? Is there 100, 200 kilos on your back? Or is it just body weight? How much risk is there? Is there any previous injury? Is there pain? And all of these things should help you decide. So Jodie Law has asked, my client has a knee injury that stops her squatting. And then she says ACL and MCL. I'm assuming that the injury is with the ACL and the MCL, Jodie. I'm sorry, it doesn't say. How can I get her squatting? Sadly, Jodie, if the injury is stopping her squatting, then you probably shouldn't try to get her squatting without working with her therapist, surgeon, or finding out more information. It may be in this case, Jodie, if you don't have a clinical qualification, that you need to refer your client for some treatment in advance. The flip side of that, and it's always case by case, I apologise for having that response all the time, but it absolutely is. The flip side of that, Jodie, is if they can get in and out of a chair, then they're squatting. So it depends on what you define as a squat. If an injury is stopping her squatting in a certain way, don't do that particular squat. If she can do a squat, or he or she can do a squat in a certain manner to maintain strength and healthy joints and soft tissue around the lower limb, fantastic, keep doing that. But it's definitely going to be very individual. So I'm sorry, Jodie, again, it's absolutely case by case. You need to speak to the other professionals. And all of these questions highlight actually what we should be doing in terms of as the consumer, the average gym goer, or as the professional, the personal trainer or the strength coach. We shouldn't be working in isolation or on our own. We should seek other people's advice and collect the data and make an informed choice on what we do with our own body. As a trainer or a coach, we should be working with people who have different skills to us: podiatrists, chiros, osteos, manual therapists, physios, surgeons, GPs, to get an all-round opinion on a client, particularly when they do have an injury or a low-grade issue. The problem is the language barrier. So as exercise professionals, we're pretty poor at remembering the appropriate language in terms of how we communicate. Because we're talking to clients all day about bums, legs, hips, rather than, specific muscles and abduction and rotation or dysfunction. So what we should be doing is brushing up on that language. It's your basic level 2, level 3 language, getting back up to date with it, and then using it to communicate with our peers. I strongly recommend you do some market research and you go and you check out the local therapists, clinicians, or other professionals within your area who have skills that you don't. Go and have a treatment or a session with them, and if you like it, you can proposition them and say, hey, I want to send my clients to you. Are you up for that? A great therapist, clinician, professional practitioner is obviously not going to turn you down. What you would hope is that they would then reciprocate. If they look at you gone out, they may be a bit old school and they may be slightly blinkered. Maybe they're not up for it. So you might steer clear. But I would definitely explore it, definitely make an effort to try and open up avenues to give your clients or yourself a multidisciplinary opinion on their body and their movement. Now, I have got one more question that I promised to answer, even though it kind of relates back to what we did on pelvis. So Debbie Gray asked a great question. She works with predominantly older or less conditioned ladies, and they don't feel their glutes are working on body weight squats, Debbie says. Her normal approach is glute activation exercises, bridges, kickbacks, band work. Some say they feel nothing in their glutes. Any ideas other than patience and consistency? Debbie, you've hit kind of a topic that is massive in the industry, and my first question to you would be, so what? So what if they don't feel it? There's too much emphasis on feeling. If they're getting up and down out of a squat, then their hips are extending, their glutes must be working. This whole language of glutes not firing, not activating, I'm sorry, it just doesn't sit well with me. If you can hip extend, then your glutes are doing that. They are the predominant hip extensors. However, are they doing it well enough? Are they functioning fully? Are they inhibited by the antagonist or the hip flexors? So the question really is, why are they not feeling it? So go back to pelvis, Debbie. Get into those antispasms around the pelvis. Look at antispasms for the hip extensors and the hip flexors as well. Once you've created that antispasm, the better function, Then get them to try squatting and see how their glutes feel. That might be one way of addressing it. So that's it for knee this time around in this particular video series. So what's next? Well, next time we're going to be looking at ankle and foot. We're going to be discussing shoes when it comes to squatting, and what I'd like you to do is send me your questions in relation to foot function when you're squatting. So till next time, happy squatting!